Hello everyone, my name is Justin White. I am the current REI Fellow at the University of Ottawa. I am presenting a retrospective analysis that was performed as part of the Department of Obstetrics and Gynecology in Dalhousie University in Halifax, looking at vaginal progesterone in the form of prometrium and comparing it to intramuscular progesterone and oil as luteal phase support in frozen embryo transfer cycles. I would like to thank Dr. Joanne Hickey, Dr. Megan Dufton, Navjot Sandila, and Dr. Michael Ripley for their assistance in helping complete this project. Progesterone is essential for the implantation and maintenance of an ongoing pregnancy, and in a frozen embryo transfer cycle, there is no physiologic corpus lutea produced, and therefore supplementation with progesterone for luteal phase support is required in a medicated frozen embryo transfer cycle. The number of FETs that are being performed worldwide is increasing, and this is for various reasons, including for the prevention of ovarian hyperstimulation syndrome, for fertility preservation cycles, and for an increased use of pre-implantation genetic testing. There have been recent studies that support the use of progesterone and oil over vaginal formulations, quoting an improvement in not only pregnancy rate, but decreased miscarriage rate and improved live birth rate. We traditionally used vaginal progesterone in the form of prometrium, 200 milligrams PV, 3 times a day in Halifax. And when these new studies started to be published, including a large trial by Shady Grove Fertility and with Devine and colleagues in 2018, we then wanted to perform a quality assurance study to see if switching to intramuscular progesterone and oil would actually result in an improvement in our reproductive outcomes. We reviewed charts from January 1st, 2017 to December 31st, 2020 at Atlantic Assisted Reproductive Therapies in Halifax. And we then compared patients who received prometrium 200 milligrams PV TID to those who received intramuscular progesterone and oil 50 milligrams per milliliter, 1 milliliter injected daily for 6 days prior to transfer. We then recorded demographic data and then assessed the primary outcome of a positive pregnancy test 2 weeks following the transfer and secondary outcomes, which were the odds of miscarriage and live birth. Univariate and multivariate binary logistic regression analysis were then performed to calculate the adjusted odds ratio and the 95% confidence interval. A total of 745 patients were included in our study. 386, or 52%, had a positive pregnancy test. Of the 386 patients, 37% unfortunately had a spontaneous abortion, but 63% achieved a live birth. There were a total of 438 patients in the vaginal progesterone group and 307 patients in the progesterone and oil group. 53% of patients in the vaginal progesterone group achieved a pregnancy, 51% achieved a pregnancy in the progesterone and oil group. As a result, there was no statistically significant difference in the odds of pregnancy and in the odds of miscarriage or live birth between both groups. If you look at the secondary outcomes by total population and group figure, 745 participants were included, and of that, 386 that achieved a pregnancy outcome, which was miscarriage versus live birth, was analyzed. In the vaginal progesterone group, of the 230 participants who became pregnant, 18% experienced a miscarriage and 34% achieved a live birth. However, in the progesterone and oil group, of the 156 participants who became pregnant, 20% experienced a miscarriage and 31% achieved a live birth. There was no statistically significant difference between these. The demographic data between the patients in both groups was also very similar, with no significant p-values between. Since the completion of our study, Devine and colleagues published another trial demonstrating that progesterone and oil improved live birth rate. Our patients were given vaginal progesterone 3 times a day compared to the twice daily dosing at Shady Grove Fertility, and this might have accounted for the improved outcomes in our study. Recent pharmacokinetic data also supports that it's the vaginal concentration and the uterine concentration of progesterone that is more predictive of better reproductive outcomes compared to serum levels. And therefore, there may be a role for a higher vaginal dosing of progesterone in these patients, and that progesterone and oil might not always be better. Multiple studies have showed no difference between both progesterone oil and vaginal progesterone. However, there does continue to be insufficient evidence comparing one protocol to another. The strengths of our study were that we reported live birth rate at a single center. There was a large sample size over 4 years of data collection, and this was a quality improvement project. Our limitations include that biochemical pregnancies were included in the miscarriage group, and we did not control for PGD tested embryos. We also then had some patients who received a combination of vaginal progesterone and progesterone oil as directed by their physician. However, these were all included in the progesterone oil group. Future studies may benefit in measuring serum progesterone level on the day of embryo transfer for better understanding of the pharmacology of progesterone and its implications in frozen embryo transfer cycles. Overall, our conclusion was that vaginal progesterone was non-inferior to progesterone oil for endometrial preparation in FET cycles at AART in Halifax. Thank you very much.